very nicely this morning, and she emphasized that we're going to look at the heart in attitudinally appropriate fashion. And so we're going to start by looking at the outflow tract to the right ventricle. So let's zoom in on beautiful. And what she showed you was that in the normal heart, we have a big supraventricular crest. Now, I would only now use this term supraventricular crest to describe this situation which we see in the normal heart. Because she pointed out to you this morning how the supraventricular crest inserts here between the limbs of the septomarginal trabeculation. Here is the septomarginal trabeculation. It has a body which comes down towards the apex of the right ventricle, and this body is quite freestanding. You see, I can lift up the body, and she also told you this morning how the body continues and joins the anterior papillary muscle, and she described the moderator band, and there is the moderator band. This heart shows us very nicely, if we back off a little bit, that in fact the septomarginal trabeculation is but one of a series of septoparietal trabeculations. And you see there are all these septoparietal trabeculations which run to the parietal wall of the right ventricle. So we have the septomarginal trabeculation, and then we have the septoparietal trabeculations. But here we see the supraventricular crest. And the supraventricular crest is inserting itself between the limbs of the septomarginal trabeculation. Here is the inferior or the caudal rim, which is giving rise to the medial papillary muscle. Here is the cranial limb that's running all the way up to support this leftward leaflet, this leftward adjacent leaflet of the pulmonary valve. There is the rightward adjacent leaflet, and the heart has been opened through the non-adjacent leaflet. Now, the larger part of the supraventricular crest in the normal heart is the ventriculo-infundibular fold. And if we go out there, you see, we come outside the heart. And I've passed that probe through there. It's come remarkably close to the right coronary artery. And that is one of the dangers of cutting through the ventriculo-infundibular fold. If I continue towards the pulmonary valve, I then find the freestanding muscular infundibular sleeve that Dr. Deshpande emphasized for you this morning, and it's the presence of that sleeve that permits the surgeon to remove the pulmonary valve and use it as an aortic homograft. Now, what Dr. Deshpande also told you is that we used to argue that in the normal heart there is a small bit of muscular infundibulum here that we can cut out and enter the left ventricle. I no longer think that is the case. And I say that because of the computed tomographic studies, the echocardiographic studies, because there is a tissue plane behind and between the aorta and the pulmonary trunk that has not been dissected here. But that means that in the normal heart, all of this tissue separates the infundibulum from that area of tissue between the aortic root and the pulmonary root. So the supraventricular crest will come apart in the setting of the lesions we're going to look at, and then we'll differentiate the ventricular infundibular fold, the outlet septum, which we can't see in the normal heart, and the septomarginal trabeculation. We then look at the outflow tract, and Dr. Deshpande beautifully showed you this morning the feature of the outflow tract of the left ventricle is fibrous continuity in its roof between the leaflets of the aortic valve, the mitral valve. But note that there is quite some area of fibrous continuity between the hinge of the aortic valve and the hinge of the mitral valve. And we know now from our developmental studies that initially there is also a subaortic infundibulum when the aortic root first gets into the left ventricle. So let's now look at a series of hearts in which both outflow tracts arise from the right ventricle, and let's look at their morphologic features. Now, all of these hearts have been very beautifully dissected, and you can already anticipate in this heart that there is going to be double outlet right ventricle, because here you see the cut that has been made from the apex of the right ventricle, taking us into this arterial channel, and you see that there is another cut that is coming from the apex of the right ventricle and is taking us into a much smaller pulmonary trunk. So this large vessel is the aorta. You can see very nicely it's swinging over. It's giving rise here to the brachiocephalic vessels, the brachiocephalic artery itself, the left common carotid artery, the left subclavian artery. And if we open up the right ventricle and we look inside it, we can see that there now is a large interventricular communication. You can also very beautifully see that here there is fibrous continuity between the between the right coronary leaflet, between the left coronary leaflet of the aortic valve and the mitral valve. There is the fibrous continuity. This is a band of fibrous tissue. There is the myocardium. You see this part is white, telling us that it is fibrous. This part is brown, which is the roof of the left ventricle. And you can also see that there is extensive fibrous continuity between the non-adjacent leaflet of the aortic valve and the tricuspid valve. So here we have the perfect situation where the aorta is exclusively arising from the right ventricle, yet there is not a subaortic conus. But I hope you all agree with me that since the pulmonary trunk arises from this right ventricle, along with the aorta, we're going to call it double outlet right ventricle. In fact, the pulmonary trunk is narrowed at its origin from the right ventricle. And here is a very tight subpulmonary infundibular stenosis. And there is then a very long infundibulum that's leading up to the bicuspid pulmonary valve. And you see that in this infundibulum there are some septoparietal trabeculations. So the reason we have this squeeze is because there is anterocephalad deviation of the outlet septum. Here is the septomarginal trabeculation or the septal band. The interventricular communication is opening to the right ventricle between the limbs of the septomarginal trabeculation. There is the medial papillary muscle. So in fact, this heart has the phenotypic morphology of tetralogy of Fallot. We have spiraling arterial trunks. We have severe subpulmonary obstruction. You see that that little thing is the left atrial appendage. So the pulmonary trunk is very narrowed between the leftward margin of the aorta, the left atrial appendage. All, effectively, the aorta is coming out of the right ventricle. And there's no real reason why we should ever have denied that you can have double outlet with tetralogy of Fallot, because when Arthur Louis Etienne Fallot in 1877 described the first three cases that we now call tetralogy of Fallot, one of the three was described by tetralogy by Fallot as having precisely this arrangement, the aortic trunk arising exclusively from the right ventricle. So a heart that hopefully puts to bed the notion that you have to have bilateral conuses to have double outlet right ventricle, and also the tetralogy of Fallot does not coexist with double outlet right ventricle. A beautiful heart. So more beautiful hearts are appearing. We were asked about juxtaposition of the atrial appendages. Well, here is the essence of juxtaposition of the atrial appendages. you see that the arterial pedicle in this instance is forming the rightward margin of the cardiac silhouette. And if we back off a little bit, you see that the heart itself is boot-shaped. And this is quite significant. It is in with outflow tract malformations that you get the boot-shaped heart. You see that there's no real ventricular apex. If anything, the apex is pointing directly down. And it could well be that some would consider this to be showing mesocardia. But what we see here is two atrial appendages. This is the right atrial appendage, this is the left atrial appendage. And even when they are juxtaposed, you can see that there is a difference between them. The left atrial appendage is much more tubular than the right atrial appendage. And if I turn back and I show you the inside of the right atrium, you see the pectinate muscles within the right atrium continue to run all the way around the atrioventricular junction. Look at the back here, moving in towards the coronary sinus. So we can still recognize that this is a morphologically right appendage. We can also see the morphologically right atrium connecting to the right ventricle, concordant ventricular arterial connections. Here is the septal leaflet of the tricuspid valve with its multiple tendinous connections. And then, arising from the right ventricle, we have an aorta with a huge muscular subaortic infundibulum this time, two coronary arteries telling us that that is the infundibulum. And then, from the other side here, we find the subpulmonary infundibulum. So we have bilateral infundibulums. This is the pulmonary trunk because the arterial trunk is branching into right and left pulmonary arteries. You see that there is severe subpulmonary stenosis. There you see the muscular outlet septum. And in fact, in this heart, the interventricular communication is hidden beneath the septal leaflet of the tricuspid valve. So unequivocally, in this instance, we have a non-committed defect. Here is the septomarginal trabeculation. The defect is not opening between the limbs of the septomarginal trabeculation. Had it been in that position, then arguably it could either have been subaortic or subpulmonary, but it is shielded by the septal leaflet of the tricuspid valve so that it is opening to the inlet of the right ventricle. Note, however, that in this heart there is still fibrous continuity in the roof of the interventricular communication between the leaflets of the tricuspid and the mitral valve, meaning that the defect remains perimembranous even though it is doubly committed. And one final point, as we look at the heart from the front, you see that the aortic root is anterior and leftward relative to the pulmonary trunk. And this is another of the variants that on occasion you can have so-called L malposition of the aorta in the setting of double outlet right ventricle. So now, another interesting, nice big heart comes into show. I show it you from the front, and already I've got the clue that I'm dealing with double outlet right ventricle. These beautiful hearts of Pradeep. He's made this cut that tells me that goes into the aorta. And here is the aorta. And you see that this time we have a rightward aortic arch. That can go with double outlet right ventricle. The other cut is going into the pulmonary trunk. And again, we have a small pulmonary trunk relative to the size of the aorta. So this time, I open the heart, and we see that there are two leaflets that are going across and entering the left ventricle. So these are bridging leaflets. And that tells me that this time we're dealing with double outlet right ventricle in association with atrioventricular septal defect. In fact, I'm not sure that that is the case. I might be telling you a lie there. In fact, it is the case. But there is also severe right ventricular dominance. So now I've turned the heart and I'm looking down on it from above. So we confirm the fact that there is atrioventricular septal defect. I'm going to point here. Okay, so let's try and orientate you. This is the inferior bridging leaflet. There is the superior bridging leaflet. And there is the crest of the muscular ventricular septum. So what you see is that almost 4/5 of the common valvar orifice are opening into the dominant right ventricle. And there is the small remnant of the left half of the AV valve that's opening into the left ventricle. And again, you can see the mural leaflet, the small left ventricular components of the inferior bridging of the bridging leaflets themselves. And then when I open the back of the heart, there we find the left ventricle. And now I've found the right way to open it. You can see the inferior bridging leaflet there, the superior bridging leaflet there, and a left ventricle that is hardly going to be able to support the systemic circulation. So here is a nice heart with a right ventricular dominant atrioventricular septal defect coexisting with double outlet right ventricle, fibrous continuity between the superior bridging leaflet and the aortic leaflet. But even though the ventricular component of the atrioventricular septal defect is directly beneath the aorta, because of the right ventricular dominance, it's questionable whether you would be able to repair this heart to achieve a biventricular repair. Too many hearts for me. Okay. So now we have a very interesting one. So there, I'm showing it to you from the right side, and you recognize there the pectinate muscles going all the way around the right atrioventricular junction. So what sort of atrium am I showing you? But now look, when we open up and show you the ventricle, that is a ventricle that has a smooth septal surface. Let's close in on the apex, and we have fine crisscrossing trabeculations. So we have discordant atrioventricular connection on the right side. And that tells us that this is going to be a morphologically mitral valve, but the morphologically mitral valve is straddling and overriding. So I was asked about straddling and overriding, and here you see a lovely example of straddling and overriding of the mitral valve in the setting of discordant atrioventricular connections. And you see that the valve is straddling and overriding towards the outlet of the right ventricle. But the right ventricle, of course, because there are discordant atrioventricular connections, is left-sided. And then when we open up the left atrioventricular junction, we see there the left atrial appendage, and the left atrioventricular junction is passing through a valve which has tendinous cords attaching it to the ventricular septum, telling us that it is a tricuspid valve. And in this instance, I don't think there is any downward displacement of the leaflets. When we look at congenitally corrected transposition tomorrow, we're going to be looking at an verebstenoid malformation. But I think this one is all right. But when we look at the outflow tract, beautifully there, you see the double outlet. So as we expect in congenitally corrected transposition, the aorta is anterior and left-sided. In this instance, it's directly in front of the pulmonary trunk, and this shows us beautifully the building blocks of the right ventricle. Interestingly, we also have the body of the septomarginal trabeculation dividing the right ventricle into two parts and giving rise to the anterior papillary muscle. So we have two apexes here in the right ventricle, two-chambered right ventricle. And we see that arising from the outlet part of this right ventricle, we have both arterial trunks. And this shows us very nicely the location of those building blocks, because that has to be the outlet septum, since it separates the subpulmonary outflow tract from the subaortic outflow tract. Here we have a large subaortic infundibulum, here a large subpulmonary infundibulum, and that is part of the inner heart curvature. You see that I can take these arterial trunks, I can pass my probe behind them, and I then show you how this fold here is the ventriculo-infundibular trunk fold. And you can also see very nicely here the straddling part of that mitral valve. It is attached here to the anterior papillary muscle of the right ventricle, and it's straddling through an anterior interventricular communication that initially would have been subpulmonary, but is now surgically non-committed because of the presence of the straddling component of the morphologically mitral valve. So a lovely heart this time, showing you the double outlet right ventricle can coexist with discordant atrioventricular connections. Is that it?
Yeah, that's it.
So that is it. So now we move on to the clinical aspects of double outlet right ventricle.
We have time for a question. Anyone? Yeah, sure.
In all these hearts of Fallow and DORV, etc., is there some degree of rotation of the aorta a little anteriorly?
There is always, it's a very good question. I mean, certainly the aortic root is rotated as it moves into the right ventricle. And interestingly, we're exploring at the moment rotation of the aortic root even in the normal heart. So even in the